Thanks.
Okay, so we'll move into the next on the agenda is Sarah Zadie, Dr. Sarah Zadie, who's the clinical lead for Frailty and Urgent Care. Going to be filling us in. Really excited to hear about this a bit further about Frailty Plus. So Sarah, over to you.
Thanks, Deepak. So we've heard already from Deepak and Emma that obviously frailty being considered is very much part of NHS long-term plan and some of the initiatives that we've got planned coming along with holistic needs assessment. And there's a reason for that. Obviously, ageing population creates greater challenges because we have a rising prevalence of frailty. So next slide. So the whole point about frailty is it's not an adjective like tall or short or fat or thin. It's a physiological altered state within the body. And that's why all the research behind frailty is encouraging us to think of frailty as a long-term condition in its own right. And the risk of developing frailty is not just age dependent. It depends also on how many long-term conditions you have. So we know that there's more long-term conditions in the population, and so we've got much more people with high blood pressure and heart disease and lung disease and various other conditions. The more long-term conditions you have, the greater chances you have of developing frailty, and or if you've already got frailty, that adversely affecting the frailty and making the frailty a lot worse, because it affects physical reserves in the body. If you throw a cancer diagnosis into the mix, then that really creates a double wham effect on the frailty. So the next slide explains that we need to shift our approach in thinking about frail elderly away from that to thinking about frailty as a long-term condition. And frailty affects the physiological reserves in multiple organs in the body: brain, body, so muscles, heart, lungs, kidneys, endocrine, immune system. It affects the whole lot. It's a little bit like a car running on empty with the petrol tank low. If physiological reserves in the body are low, the ability for the body to tolerate illnesses and disease, but also the treatments for that illness and disease, are massively compromised and adversely affected. And we've heard a lot about personalisation being so important, and it is important for every person, but it is never, frailty group, it's the most important thing that we can do, because if you have frailty, you are unique. Every person is different, and that's why personalisation is so important for the person. And the severity of frailty on its own is an independent predictor of adverse outcomes, including crisis risks, hospitalisation, increased dependency needs, and reduced life expectancy. Frailty often presents with what we call frailty crisis syndromes, commonly falls, reduced mobility, confusion, which can be temporary or permanent or a mixture of the two, incontinence of bladder and bowels, and the fourth one, very commonly forgotten, a much higher increased susceptibility to the side effects of medication. And that's not just new medication we might be considering for the person. It may even be medication that they've taken for years and previously tolerated well, but once they develop frailty, they're much more likely to develop side effects, and the risk of harm from that medication becomes higher than the risk of benefit. So the next slide is that we need to think about frailty as a very practical concept in the management of any person who's older, anybody with multi-morbidity and complex care needs. And identifying frailty is critical, because if we don't identify it and consider it in our management decisions and our discussions with patients, inadvertently we can have a petrol on the fire approach, and actually we can inadvertently make things much worse for the person and then cause them to deteriorate far more rapidly. So failure to detect frailty and consider it means that we as professionals will very often make poorer quality management decisions, which can actually create inequalities in terms of poorer health and well-being outcomes. The other thing to consider with frailty is that whilst it can also get worse, we can very often help stabilise or even improve it slightly, but that completely depends on how we as professionals approach the issue and that we understand the issue. And the big three things with frailty is personalisation, thinking ahead, so anticipatory care, thinking what next, and also with our holistic needs assessment of the person, it's a whole person approach, and the domains of comprehensive geriatric assessment, which considers a person's functional needs, their mood, their memory, as well as their social care circumstances, in addition to the medical and physical problems affecting that person, is the strongest evidence-based tool for holistic needs assessment. And if we use those approaches, we can actually help to reduce the acceleration of frailty in a lot of people, and or at least slow its progression, and or at least stop making things a lot worse for the person than it could be. And when we don't detect frailty, sometimes if the frailty is significant, we might be exposing people to interventions from what they may not benefit from, and actually they might actually be harmed from. And particularly with the cancer diagnostic and treatment pathway, a lot of the diagnostics can be quite aggressive, a lot of the treatments can be quite aggressive, and if you've already got severe frailty, we can actually cause more harm than benefit to people. Next slide. So the way to think about frailty is this altered physiological state. It's just like thinking that, you know, newborn babies have a different physiology and therefore we treat and manage them differently. It's exactly the same with frailty. There's an altered physiological state. And what that means is how the body responds to illness or intervention is different. And the green line at the top is meant to represent somebody who doesn't have frailty, somebody who's quite fit and active and you know, has got good physical reserves. If they get an illness or if they have treatment, usually their recovery will be quite quick and they'll just go back to their baseline. Whereas if you have frailty, which is what the red line is meant to represent, the illness, whether it be a minor illness or a more severe illness, or the treatment that we provide for that illness, can have a much more dramatic effect on somebody's functioning. And also their recovery is so much slower, and even when they've fully recovered, they may not be back at the previous level of functioning that they were. And so we need to consider that in how we process people through the cancer pathway. Thinking about the things like prehab that Emma talked about as being a good intervention to prevent that big dip and help the recovery process, but also considering that at the higher levels of frailty, as frailty becomes more severe and we get to the more severe end of frailty, that creates far more uncertainty, and we need to embrace that uncertainty and be honest and communicate that uncertainty with people so that they can have more choice and control about what happens next. And early intervention, early detection of frailty can really change the frailty trajectory. And also understanding that with frailty there comes fluctuations, ups and downs, good and bad days, and that's not just because something new has happened to the person. It could happen just because of the frailty itself, and we need to consider that and use that when we're observing people, and not be quick to jump the gun and presume that there's another cause behind the fluctuations, because very often there isn't. Next slide. So what this means for frailty and cancer, and I think some people covered this, emergency presentations of cancer are far more common in the frailty group, and that's because when there is frailty, they may not always present in the traditional ways that certain cancers do. They might just present with a frailty syndrome, so they might just present with falls, and falls are actually postural drops in blood pressure are actually known to be a paraneoplastic syndrome for people with frailty, or they might present with confusion. And very commonly this is leading to late diagnosis of cancer because people jump the gun, think that there's another cause behind it, think it might be just an infection or a UTI, and actually it wasn't, it was a cancer. So late diagnosis of cancer is far more common in people with frailty. And the other thing is that where there is frailty, the body is unstable. And that means that there are risks that people can deteriorate far more rapidly, or they can fluctuate more wildly whilst they're waiting for diagnostics and treatment. So it creates a bit of a challenge because people with frailty have a much narrower window of opportunity to gain optimum benefit. So if we're going to make the diagnosis, we need to do it as quickly and efficiently as possible. And then if we're planning treatment, we don't really have time to wait. And if somebody would benefit from prehabilitation, then we need to make sure that we're doing that as quickly as possible for the person. Otherwise, it may become too late and their frailty may progress. And I mentioned before, when there is more severe frailty, it means that some of the diagnostics and treatments might be poorly tolerated by that person and may cause more harm than good. The way that the frailty affects the cancer itself is also something to consider. So the cancer disease or treatment can drive and accelerate frailty progression. And when we're talking about what people might expect from cancer treatment outcomes, they're much harder to predict in somebody with frailty. So giving people statistics on what happens on in the normal population may not be applicable to that person with frailty, and we need to talk about uncertainty so people have more information for them to make choices about what they want to happen next. And most importantly, we need to bespoke the pathway and individually tailor that to the person based on their unique needs, their preferences, and that's the best way to reduce avoidable harms and optimise the best potential outcomes for the person with frailty. Next slide. So what we've been trying to develop in Mid and South Essex, which is part of the Ageing Well programme, is we're trying to develop a framework that all professionals can adopt in their approach to managing people with frailty. We've come up with an acronym which is Frail Plus, which stands for Find, Refer, Assess, Intervene and Listen to. And what we want this framework to be is a real quality of practice change tool, aligned to what works best for people with frailty. And if we adopt this approach, and all professionals that are dealing with adults, whether you're in the community system or whether you're in secondary care, if we adopt that approach, understanding how to find and stage frailty using the clinical frailty score of 1 to 9, that we're much better at cognition and memory and mood screening, and we're also proactive in identifying people who may have end-of-life clinical indicators, and that we are capable and understand what the high impact actions are, what are the actions that make the most difference to people with frailty. And then we actually use that in our approach to managing people with frailty, whether they be on a cancer pathway or any other long-term condition pathway. We can better improve outcomes and reduce inequalities that face this population. We've developed some tools to try and help us with this. We've got a tool in System 1 called Frida, which is a tool that we can use to deliver real personalised care and support planning, whole person assessment based on the domains of CGA, and advanced care planning for the people that really need that, and that we do that as a system. Whether we work in secondary care or whether we work in the community, particularly focusing on delivering that in the place where people live, which is usually their home. Next slide describes the Frail Plus principle and what we want all Frail Plus practitioners to be, because we have to remember that we're only going to win and do things well if we make this an everybody's business thing. This is all our businesses. If we are working with adults, we will be seeing more and more people with frailty. So we've all got to become more skilled and confident in knowing what works for frailty and what doesn't work for frailty. And so we've got a training program that's coming online much more in depth for all people across the ICS to help people to feel more confident and empowered to find people being confident in using the frailty score and the other markers. And that when we work as a system, we really do join up in the ways that Liz commented on earlier. We've got to become one system. We break down organisational boundaries and we really wrap ourselves around the changing needs of the person and align our approach so that we're all singing off the same hymn sheet, and that we understand that whole person assessment based on the domains of CGA is the best way to do that, and listening to the person the whole time and having those good conversation skills and that self-awareness. Are we really providing good information and balanced information to the person so they can be more empowered to have choice and control, express those choices, and then we as professionals listen to them and respect them, and that we focus on what matters most to the person in their unique circumstances. And the next slide just describes the 7 high impact interventions that we know make a big difference to people with frailty. And this comes from the National Ageing Well program, the big seven, which is finding the frailty, using CGA as our whole person assessment tool, and then really focusing on the big issues that can affect people with frailty, medication being one, and actually becoming much smarter with our approach to prescribing and de-prescribing. And we know there's a lot of evidence that if you're on more than 5 regular medications, your risk of adverse health events really increases. If you're on 10 medications or more, then the chances of you having an adverse effect on your health within 1 year is more than 90%, so that we are actually good at reducing medication that can accelerate harms, and that we also consider the challenges on frailty and their mobility and falls being a big thing. And then for people who might be nearing end of life, and that's anybody for a frailty score of between 7 and 9, then we would actually consider that prognostic uncertainty and focus on what the person wants to happen in the future with advanced care planning. Next slide. So we've heard from some of the presentations already that the frailty score is going to be appearing on our 2-week wait referrals for people over the age of 65, and it's also within Beetroot C, we just heard. But there's no point in doing a frailty score if we're not then going to do something with that information and change our approach. And the frailty score scores how severe the frailty is, whether it's mild, moderate and severe. And we know that the approach that we then take, whether it's mild, moderate or severe, needs to change. So for people with mild frailty, that real use it or lose it, keep people active, reduce loneliness, connect people in activity networks, and prehabilitation for people on cancer pathways massively makes a difference to people's outcomes. But once we're getting into the more severe stages of frailty, like moderate and severe frailty, we have to embrace that there's far more uncertainty for the future, and we really need to focus on what outcomes matter most to that person for their quality of life, and to reduce avoidable harms to people from either cancer treatment or the cancer itself. Next slide. So the shift is whole person care and support planning. And this is a slide that's taken from one of the gurus of frailty, nationally, Professor John Young. It's quite young, quite old actually. This is 7 years old, this slide. But really the shift is that we move away from individual guideline-based medicine to assessment of the whole person with care and support planning. And that works much better for people who have frailty or for people who have multiple long-term conditions. And on the next slide describes what the difference is. So we're not chunking people up into their individual conditions, which is how we often do things. And I think in primary care, we would recognise that this is what we do. We bring people in for their heart failure review and then their COPD review. And then we've got a cancer care review, and we're chunking people up into their individual conditions. That approach is fragmented. It doesn't work for people with frailty, and it doesn't reveal the outcomes that matter most to the person. So rather than fragmenting that person's reviews into individual packages, we're looking at the whole person, and actually allowing them to express, well, how are their lives being affected at the moment? What's important to them? Maybe they don't want to take all these tablets, and maybe we should reduce them. And maybe they do want to focus on spending more time with their loved ones. So maybe we should focus on how we can help people to spend less time in hospital and spend more time at home. Next slide. So we've developed a care planning assessment, care coordination, anticipatory care, all-in-one template within System 1. And we've got such a high use of System 1 across the ICS, with most of our community providers, almost 100% of primary care, out of hours, community nursing, all being on System 1. We thought we would try and maximise the potential of that gift by having a holistic tool called FRIDA, which stands for Frailty, End of Life and Dementia Assessment, as our way for delivering personalisation. And we know that personalisation makes a difference. The evidence base behind it is growing. It helps people not just to live longer, but better as well. And it makes sure that the care that we deliver is of higher quality and people have a better experience of care. Frida is based on the domains of comprehensive geriatric assessment. So it looks at somebody's functioning, their social care circumstances, their memory and mood, as well as their physical conditions. And that means that we're effectively delivering CGA through using Frida. And we know that CGA is the strongest evidence-based tool at reducing premature mortality, hospitalisation risks, and long-term high dependency risks for people with frailty. So using Frida helps us to deliver more CGAs. And it also contains advanced care planning, particularly for people that might have a limited life expectancy and maybe in their last year of life, because choice and control matters to people. And by doing so, we help them to live better as well as longer. We've launched Frida first of all in South East Essex, but we have a programme to get this ready across the whole of Mid Essex and South West Essex by Q4 of this year. So that's March 2022. And that tool will be localised for those local systems in South West Essex and Mid Essex. And there will be some training to support understanding how to get the best use of Frida for professionals in the system. So finally, I think this is, this is, if you just click that again, whoever's driving. Oh, no, go back. Oh, yeah, just do another click. Yep, sorry. Oh dear, sorry. So when thinking about the cancer care review process, we're trying to embed the Frail Plus framework at every stage of the person's journey. So at presentation, when people first present with symptoms, that we are actually finding the frailty, and we're also discussing the treatment pathway with people prior to the point of referral, actually tailoring that decision to refer depending on whether they want to be referred and what the best way to make that referral is, and that we include that frailty information on the referral if we're making a referral. And then at the cancer care review process, that we really do embrace the Frail Plus principles during our cancer care reviews and also post-treatment cancer care reviews. And as Liz said earlier, this will only work if we join together as one system. So with secondary care and community care all adopting the same processes, and also that we make the best use of the tools that we've got available to help record frailty scores and CGA-based assessments and get that working right across the community system. And then finally, just some take-home messages to consider that where there's frailty, we know that affects the cancer journey. It does create far more uncertainty with regards to the impact of not just the cancer itself, but also the treatment that can be provided for it. That we need to understand that everybody with frailty is different, so we really do need to adopt that personalised approach and that holistic assessment of the whole person, that we get better at providing information that's relevant to the person in their circumstances, explaining pros and cons so that they can make better informed decisions about what really is right for them. And then we respect those decisions and that we tailor our approach based on the decisions that they make. And that's shared decision making. That means that we're making decisions with people rather than for them, which is what we very often do. And that finally, if we are referring people through the cancer pathway, that at every stage of that journey, through diagnosis, treatment, recovery, that it's specifically tailored to their unique wants and wishes and circumstances, including if the frailty severity is changing. If we do that, we know that we can reduce the inequalities that are affecting this group particularly, and we can also make our teams and services work far more efficiently. So that's moving away from the reactive firefighting that is overwhelming the system to actually delivering much more efficient care. And as I said before, we've got a lot of in-depth frailty training coming on for the partnership through various training modules, which are both virtual and face-to-face. And we would encourage all people who want to get involved in the training to take that up when it will be available next year, because there's a lot to understand with frailty, and we're hoping that everybody can become Frail Plus practitioners in the system.
Sarah, that was really that was great. Thank you so much. And it's something that's very exciting. And again, bring it back to something that you just said now about these changes having to happen system wide. And I think personally, I don't know whether others would agree with this as well, but this is really the first time that I think a training package has been open to everybody within the system, community providers, secondary care, primary care. So it is really exciting. And the tiered structure that you've got and pulled together is just absolutely marvelous. So and this is definitely one of the right forums to be sort of promoting that at. Are there any questions at all for Sarah on anything about Frailty Plus at all? Oh, fantastic.